Hello and welcome everyone to another Saturday radiology session by Team Radiogan. Today's session is going to be very special. Today we have Dr. Terry Minuk with us, who's a clinical associate professor at McMaster University, Canada. He's also the head of breast imaging at Hamilton Health Sciences, and he works at Jurowinski Hospital. Although he does predominantly breast imaging, I have interacted with him during my fellowship, and apart from these credentials, these are great. But he's one of the kindest and the most fun individual to work with. So, with that introduction, without wasting any further time, I would request Dr. Minuk to start his presentation. Over to you, Dr. Minuk.
Thank you, Amar. Today, what we're going to do is look at microcalcifications in the breast and try and develop a logical approach on when to biopsy them and when not to. So I may not be able to tell you if these calcifications are benign or malignant, but at the end of the talk, you'll know exactly how to handle them and deal them. Now, it's helpful to review some normal breast anatomy when you're looking at calcifications. So this is a little redundant, but let's just go through. On the schematic on the left, the arrows are pointing to costochondral cartilage. Now, you won't see that on a mammogram, but you will see it on ultrasound. And the red arrow is pointing to shadowing costochondral cartilage. Anterior to that, you have the pectoral muscle that you'll see on mammo and ultrasound. And anterior to that, you get the fibroglandular tissue. Now, on ultrasound, the fibroglandular tissue is pointed out by the red arrows. The glandular component is dark. It's not the whiter part. The whiter part is fibrous tissue. The dark part is the glandular tissue. So if a lady gets pregnant, her breast will become filled with these dark areas. It'll look like she has a fatty breast, but in fact, it's full of glandular tissue. Now, we have a schematic on the left of the duct system. There's about 15, 20 ducts that extend from the nipple into the breast. And the image on the right is a ductogram, and we've injected some contrast into the ducts. And what you'll notice here is some of the ducts extend to the top of the breast, where the black arrow is, and some go to the bottom. So you'll see some ducts going to 12 o'clock and some to 6 o'clock. And if you had calcifications in that one segment, they may go from 12 o'clock to 6 o'clock. On a mammogram, you would think that's multi-segmental, being in the upper half and the lower half of the breast, when in fact, it's really the same segment. You just can't tell. Now, at the end of the ducts, we have leaves, and those leaves are known as TDLUs, terminal duct lobular units. All the interesting pathology in the breast occurs in the TDLUs. And so that's where we're going to spend our time, because this is where the interesting calcifications arrives. There's a histologic specimen of a TDLU on the right. They measure about 2 millimeters by 2 millimeters, but premenstrually, they may go up to 4 or 5 millimeters in diameter. And they consist of two components. One component is the terminal duct. The terminal duct is lined by a single layer of epithelial cells, and that's lined by a layer of myoepithelial cells. Almost all breast cancers occur in the terminal duct. It doesn't matter if they're lobular carcinoma or ductal carcinoma, they arise in the terminal duct. These are like stem cells, and they can develop into lobular cells or ductal cells. The second component of the lobule consists of acini. These are like the fingers on a surgical glove. They make milk when you're pregnant, or they make fluid when you're not pregnant. And they're surrounded by a loose connective tissue. You can see outside of the red circle, there's dense connective tissue, or dense stromal tissue, and in loose connective tissue. On mammograms, the TDLUs are these little white circles. Now, if they're surrounded by fat, you'll see them. If they don't have fat surrounding them, then it'll be a sheet of white. But you will see them on the mammogram. And they tend to be similar in size throughout the breast. Now, on the right are multiple TDLUs. Now, you'll notice that there's a lot of acini in the TDLU that's circled. There may be anywhere from 10 to 100 acini, and those acini change each month. So premenstrually, you may have 50 acini, and postmenstrually, you might have 10. So in other words, they'll increase premenstrually, and not only do they increase in number, they will increase in the volume of fluid they hold. And the loose connective tissue between the acini, it will get more edematous premenstrually, and hence premenstrually a lady's breasts swell and they get a little tender. It's because there's increased number of acini, increased distension of the acini, and edema of the loose connective tissue, and that's normal. So, and there's lots of TDLUs throughout the breast. Now, when we talk about calcification, it's helpful to look at the shape of the calcification to gauge where it might have arisen from. Now, ductal calcifications are linear and they track within a duct, and they tend to be in a segmental distribution. So when you look at the calcifications that I've shown there, you can tell they're long, in this case, rod-like calcifications. They're obviously arising in a duct. The other calcifications are we call lobular morphology. They look like they've arisen in an acini. In this case, they're different sizes and shapes and densities. And they look like they've arisen in an acini, but we know one thing about these calcifications. About half of this type of calcification are malignant. Different sizes, different shapes, different densities. That's suspicious for malignancy. And we said earlier, almost all malignancies occur in the terminal duct. So how is it possible that calcifications like this, that look like they arose in an acinus, how is it possible they could be malignant? Because that would imply they arose in this terminal duct. We'll come to that. Now, when we look at ductal calcifications, there's two types. Basically two types. There's other types, but there's mainly two types. They're very easy to deal with. We should never make a mistake in biopsying ductal calcifications. They're very straightforward. One is the benign etiology, and these tend to be large rod-like calcifications. That's a BI-RADS term, and it tends to be what we call secretory disease. Now, secretory disease occurs in pre-existing ducts that are lined by a single layer of epithelial cells, and they're calcification of secretions in those ducts. These ducts are often a bit ectatic because there's often inflammatory changes around the duct, and those inflammatory changes have plasma cells. So it's known as secretory disease or plasma cell mastitis. So these large rod-like calcifications exist in a normally lined duct, and they tend to be smooth and contour. On the other hand, these suspicious calcifications occur in a duct that's not lined by a single layer of cells. It's got heaped up tumor cells lining the wall of the duct. And those tumor cells will die and slough into the lumen of the duct. And then you'll get calcified debris within a duct. And that calcification will form a mold of the duct. And if there's a lot of necrosis, you'll get big chunky calcifications. If there's a little bit of necrosis, there'll be small little calcifications. And sometimes the calcifications are just broken into multiple tiny pieces. Tapar calls it a snakeskin appearance. The important point with these suspicious calcifications is they look like they've arisen in a duct that's got irregular walls because the calcifications themselves are irregular. So let's look at some benign morphology calcifications. These are the large rod-like calcifications. You can see they're dense, they're easy to see, they're relatively smoothly contoured because the duct that they have arisen in is smooth. But every duct is not perfectly smooth, and so you will get some lumpy, bumpy changes along the ducts. Don't expect every calcification to be a long linear calcification. Some of them are small. The odd one might be a little bit irregular, but overall, the overwhelming majority are smoothly contoured, dense, easy to see. Now, this is a classic appearance of plasma cell mastitis or secretory disease. It's bilateral. It involves segments in the top half and the bottom half, the medial and the lateral breast. It's multi-segmental and it's bilateral. And that tells you benign disease. And you don't want to be biopsying these calcifications. Yes, you will see the odd irregular calcification. It doesn't matter. This is secretory disease. It's calcification of benign secretions. These people are asymptomatic. It's predictable, these calcifications, because they occur in pre-existing ducts. And so when you look at it, you could almost draw the duct system of the breast. Now, not all secretory calcifications are as obvious as in the last case, but in this case, they are subareolar, bilateral, just not as numerous as in the last case. Now, I'm just going to sort of go on a tangent here. You can see my arrow is pointing to a long linear fragmented duct, fragmented calcification. That's a calcified artery. And if you look, you can actually see the artery branching. And if ever you weren't sure, you'd mag it and then magnify it, and you would see that that is clearly a calcified artery. Here's some large rod-like calcifications. It's a little bit more unilateral, but the appearance is identical. There are some on the other side. They're just not as numerous. But that's secretory disease. Get a feel for what they look like because they're benign and you never want to biopsy them. When you see the malignant intraductal calcifications, they're a completely different kettle of fish. So we've looked at benign morphology ductal calcifications. They tend to be large rod-like calcifications. There's other calcifications that are benign. You know, you can get calcified arteries. You can get calcified sutures. Rarely you'll get fibrocystic change that'll have linear calcifications. And every once in a while you do biopsy them because they don't look totally benign. Let's now look at the suspicious morphology calcifications. These are BI-RADS 4C. They have a greater than 50% chance of malignancy, probably in the range of 90%. When you see these are malignant and you'll know it. They tend to be fine, linear, branching calcifications. They're ratty and irregular. Let's look at a case. When you look at this here picture on your left, there's absolutely no question these are arising in a duct because when you look at them, they're tracking in a long linear fashion and they do branch. So they're interductal. They're fragmented little pieces. They're not the long rod-like calcifications we saw with a secretory disease because these are arising in a duct filled with necrosis. So these calcifications you've seen are necrotic intraductal debris. The calcifications themselves are totally benign. They're necrotic debris. If you leave them long enough, you'll get more and more necrosis and the calcifications will get big and chunky. So if you want to wait a long time for your DCIS because you think it's benign, the calcifications may get bigger and chunkier. They may not always tell you that they're malignant. Let's look at the pathology of this. The pathology at the top shows a long branching duct filled with tumor cells. So that's what would be called solid DCIS. Now it's surrounded by some purple cells, which is inflammatory, a desmoplastic reaction that frequently occurs with high-grade DCIS. Now, if we were to do to cut this in cross-section and look at it, it'll look something like this. In the top left, the black arrows are pointing to solid DCIS cut in cross-section. The duct in the middle is a duct that has central necrosis. Now, the pink on the outside is the thickened wall of the duct with heaped up tumor cells. Inside that is necrotic debris. And this is necrotic tumor cells. And I know that because there's all kinds of little purple cells along the periphery that the arrows are pointing to, and that's nuclear debris. The tumor cells have died, the nuclei have been sloughed into the lumen, and this is nuclear debris. And in the very middle, you get fragmented calcifications, and that's what we're seeing on the mammogram. We're just seeing the calcifications on the mammogram. We're not seeing the tumor outside. We're not seeing the wall of the duct. And so the high-grade casting calcifications that form a mold of the duct, they're high-grade DCIS. They may go on and form invasive ductal carcinoma. We tend to see them easily on the mammogram if they calcify. Sometimes, though, high-grade DCIS doesn't calcify. You get necrosis, but you don't get a lot of calcifications in the lumen. And those ones you may pick up better on MR. Here's another case, extensive linear branching calcifications. And when you see this, your question is this DCIS, invasive cancer, or both? And when you look at those calcifications, there's some soft tissue thickening around them. And that raises the possibility of invasive cancer. And if you have your druthers, you want to biopsy the invasive cancer, not the DCIS, because the surgery is different. So you might, on this one, go ahead and do an ultrasound looking for a solid component, and then you'd biopsy the solid component. Now, what makes this more or less likely to have an invasive component? There's three main things that we would look at as radiologists. One is the single largest dimension. If the extent of the calcifications is more than 4 centimeters, the risk of invasion is higher than if it's 2 centimeters. Similarly, we have different types of calcifications, and the linear branching calcifications, as you see here, are more apt to be associated with invasive disease than the pleomorphic or amorphous calcifications that we'll be talking about shortly. And the younger the patient is, the greater the risk of invasion. So if you're under 40, your risk of invasion is going to be significantly higher than if you were over 60. So extent of disease, type of calcifications, and age of patient help to determine if this might be invasive. Ultimately, you need the pathology to tell you for sure. Here's just another example of high-grade linear branching calcifications. You can see from the arrows, some of these calcifications are thick, but they're running in a linear distribution. It's that distribution that tells you these are in a duct, and the ratty, irregular nature, all different sizes and shapes and densities, that tells you high-grade DCIS. So ductal calcifications are secretory disease or low-risk disease, and no risk of cancer in these. High-grade DCIS, on the other hand, looks completely different. The only difference between the two is that they're arising in a duct. In one case, BI-RADS 4C, chance of this being cancer approaching 90%. I look at this, I'd say, well, that's 100%, but people might say I'm going overboard, but these are cancer. These are benign. Don't be biopsying secretory disease. We already biopsy too many cancers, too many calcifications. Now let's look at the tough calcifications, the ones that are lobular morphology. They look like they arose in an acinus. And there's two types, basically. There's ones that have a suspicious morphology, and then the other group that have a benign morphology. BI-RADS divides these suspicious ones into 3 groups: coarse heterogeneous, that look like chunks of broken glass. The calcifications are bigger than 0.5 millimeters. Fine pleomorphic, smaller calcifications, maybe like a few grains of sugar ground up into smaller pieces. And amorphous, they're powder-like calcifications. You can barely see them. They're almost like talcum powder. Now, as you go down the list from coarse to fine to finer, the risk of malignancy goes up. It doesn't mean the risk of killer cancer goes up, because the amorphous calcifications have the highest risk of malignancy, but they tend to be low-grade malignancy and won't affect your life anyway. Now, BI-RADS has chosen these terms, which don't make a lot of sense, because heterogeneous means different size, different shapes, different density calcifications. Pleomorphic means different size, shape, and density calcifications. They mean exactly the same thing. So I lump these two together into pleomorphic calcifications. Some of them are fine, some are coarse, but you will almost never see coarse heterogeneous calcifications only. You almost always get a mix of the two. So why BI-RADS has chosen to differentiate them is that the pleomorphic calcifications have a slightly higher risk of malignancy than the heterogeneous calcifications, but they tend to occur together. So let's look at them. Now, here's calcifications that are different sizes, shapes, and densities. Some of these are bigger than 5 millimeters, so BI-RADS would call them coarse heterogeneous, but other calcifications are under 5 millimeters, so BI-RADS would call them fine pleomorphic. I just call them pleomorphic calcifications. The risk of malignancy in my hands is 30 to 50%. If you biopsy every calcification you see, your risk of malignancy might be 20%. And that's because you're biopsying too many calcifications. And in the US, they tend to biopsy a lot of calcifications. It's a litigious country. People tend to be overcautious. They biopsy more calcifications than it's necessary to biopsy. And hence, the risk of malignancy in their biopsies will be lower. But these calcifications here, 30 to 50% risk of malignancy. Those that aren't malignant tend to be fibrocystic change, maybe 30% of them. Calcified fibroadenoma, maybe 10, 15%. And there's other things, dystrophic calcifications. But when you see calcifications like this, what you want to do is look at the distribution. Distribution is really important. If you see these calcifications diffuse, which means all over both breasts, they're benign. Doesn't matter what they look like. If they're bilateral, all over both breasts, they're benign fibrocystic disease, period and end, next case. Now, if they're grouped, and BI-RADS says a group of calcifications is more than 5 calcifications in a sonometer. So if you get a little group of calcifications all by itself, nothing else, be concerned. Be concerned of cancer. But they could also be fibroadenoma or fibrocystic change or dystrophic calcifications. Regional calcifications are more than 2 centimeter diameter of calcifications, but not in a segment or not in a ductal distribution. So the grouped and regional calcifications have a higher risk of malignancy than the diffuse. The diffuse don't have much of a risk of malignancy. Now let's look at these calcifications, because I'm telling you these are different sizes, different shapes, different densities, therefore they're pleomorphic. And in this case, these are malignant. And if they're malignant, that means they must have arisen in the terminal duct. How is it possible that these lobular appearing calcifications could possibly occur in a terminal duct? And to understand that, you have to go back to the ductal calcifications for a second. We know the high-grade DCIS are linear, irregular calcifications arising in a duct, and the calcifications are necrotic debris within the lumen of the duct. Now, let's look at these calcifications, these lobular calcifications that are malignant, and see what's going on in this duct that could account for this. So here's a cross-section of a duct full of these calcifications. Now, this is known as micropapillary cribriform DCIS. Now, we saw earlier solid DCIS. Well, another type is called micropapillary, and another type is called cribriform. Now, in the old days, this is the morphology of DCIS. In the old days, that's how DCIS was classified. Today, we call it high grade, low grade, intermediate grade DCIS, or we use receptor status, molecular findings, ER positive, PR positive, HER2 neu positive. So we use different molecular features for DCIS today. But this here in the pathology is a long papillary growth. This is micropapillary DCIS. Along the periphery of the duct is cribriform DCIS. It's heaped up tumor cells. They form like canals of Venice, and they leave holes in the wall like Swiss cheese. And where those holes are, you get secretions, and you may get calcification in those holes. And so the calcifications you get here may be different sizes and shapes and densities. They tend to be predominantly calcified secretions. So what's happening in this terminal duct is you're getting these papillary or cribriform growth patterns, and you get calcifications in those cribriform holes, and it causes this appearance of calcifications. This tends to be an intermediate or low-grade DCIS, not like the ductal calcifications of high-grade DCIS. So the pleomorphic calcifications tend to be DCIS, I find about half the time. Or the other most common is fibrocystic change or fibroadenomas, and there's other causes. But sometimes you cannot tell whether they're fibrocystic change or fibroadenomas, and you have to biopsy them. There are some features of fibroadenomas, if you get calcifications in a well-circumscribed mass, that's likely a fibroadenoma. If you have fibrocystic change and you do a magnification of you often see much more extensive calcifications all over in other parts of the breast, and that tips you to fibrocystic change. So here's some examples now. Here's calcifications that are pleomorphic in appearance. Some of them are coarse, some are fine. The group is under 2 centimeters in diameter. And so this is biopsy-proven DCIS. Now, someone may ask, could these be in a linear distribution? And the answer is yes. And if you think they are in a linear distribution, then that would make this more likely to be high-grade DCIS. And the biopsy would tell you that. Here's a case of multiple clusters of pleomorphic microcalcifications. Some of them are coarse, some of them are finer. So BI-RADS divides it into 2. As far as I'm concerned, these are clustered pleomorphic microcalcifications. They have a high risk of malignancy, and in this case, they're DCIS. Could this be multiple calcified fibroadenomas? Yes, it could. Could it be fibrocystic change? Yes, it could. You don't know, you have to biopsy it. Here's fibrocystic change. Multiple coarse heterogeneous calcifications. There's some fine pleomorphic ones as well. When you magnify it, what you'll notice is there's some calcifications way out in the periphery here. So, I mean, you sometimes can't sort out whether this is fibrocystic change, but again, if you have calcifications all over the breast, it's fibrocystic change. But sometimes you get a cluster like here, and that are more dominant and more grouped together, and you sometimes have to biopsy them. You don't have a choice. Now, here's the circumscribed mass. Forget the calcifications in it. If you just had the circumscribed mass, you'd do an ultrasound, you'd see a circumscribed mass, you'd get the patient back in 6 months for a follow-up ultrasound and follow it for 2 years. Now, within this mass, though, we have these coarse heterogeneous calcifications. This is still overwhelmingly a calcified fibroadenoma. And why do I say that? I say that because within fibroadenomas, you do get cancer. But when you get cancer, it tends to be lobular carcinoma. Ductal carcinoma within a fibroadenoma is rare. It's publishable rare. It occurs, but it's very uncommon. So when you get a circumscribed mass with calcifications in it, if you start seeing some coarse calcifications and think it's a fibroadenoma, that's when you can probably follow. Here's another case of DCIS with different size, shape, density calcifications. Again, it's in a group under 2 centimeters in diameter, so you have to biopsy it. So here's a summary of these lobular pleomorphic calcifications. There's DCIS, fibrocystic change, fibroadenomas. Here's a papilloma. They all look pretty similar. And unless they're diffuse all over the breast or there's other features that favor that it's a benign lesion, they all have to be biopsied. But overall, if you take them all, half of these are going to be malignant. So we've looked at coarse and fine pleomorphic microcalcifications. Let's look at the other suspicious morphology, the amorphous microcalcifications. Now, the picture in the middle shows some coarse, heterogeneous, and fine calcifications, but you get the appearance that there's clouds here of whiteness, and these are thousands of tiny, tiny, tiny calcifications. They're too small to see clearly, but they are mixed up with some other pleomorphic calcifications. Now, these calcifications may have arisen in the acinus, and if they arose in the acinus, they're sclerosing adenosis. And sclerosing adenosis is just part of the spectrum of fibrocystic change. It's associated with other proliferative breast diseases, papillomas, ductal hyperplasia, medial scars. But they can look like that, and if they arose in the acinus, that's what they will look like. Now, sclerosing adenosis tends to be bilateral, diffuse throughout both breasts. But sometimes the calcifications show up in a small area only. 10 years later, they'll be all over both breasts, but at some point they may be in a 2 centimeter cluster and you end up biopsying them. But let's look at the pathology now of sclerosing adenosis and ask, why are these calcifications so tiny and other ones were more coarse or fine? So here's sclerosing adenosis. The schematic picture, these are all Tabars. I don't know if you know Laszlo Tabar is a radiologist who done a lot of work on breast cancer and radiology, and is probably the greatest breast cancer teacher in radiology that has ever lived. Here's a normal TDLU with normal acini. On the right, you have sclerosing adenosis. Now, sclerosing adenosis has 3 components. One is adenosis. Adenosis just means increased number of acini. So there's increase in the number of acini. Sclerosing, that's number 2. The loose connective tissue surrounding the acini becomes more densely sclerotic. So when you look at the histology in the bottom, you can see the dense pink background as opposed to the loose connective tissue between the acini on a normal TDLU. So sclerosing adenosis has sclerosis, adenosis, and the third component is distortion. The acini all get distorted. So below is a TDLU involved with sclerosing adenosis, but look how tiny those acini are. There's thousands of tiny, tiny acini throughout the segment here. Pathologists can't look down the microscope and determine if this is benign or malignant. They need to see myoepithelial cells around the acini. So they'll do an actin or a myosin stain to see if they see myoepithelial cells. If they do, it's benign sclerosing adenosis. But you can see if you got calcifications within these acini, they would be very, very fine and very, very powder-like. Now let's look at malignant amorphous microcalcifications. Again, powder-like, hard to see. We severely underestimate the extent of these calcifications on mammography, even with magnification views, because they're so hard to see. But it probably doesn't matter because these are low-grade, this is low-grade DCIS, probably would never affect your life anyway. If you left it alone and did nothing, you'd probably be fine. But here it is, multiple clusters of pleomorphic microcalcifications. Here's the histology on the top. And if you just zoomed in, you can see the multiple tiny cribriform spaces throughout this specimen. It looks much like, when you look here, it looks much like sclerosing adenosis, but around these tubular areas, you would not have myoepithelial cells. So this is low-grade DCIS. So we've looked at the suspicious morphology, the coarse, heterogeneous, the fine pleomorphic, and the amorphous. Let's look at the benign. The benign is straightforward. You don't want to be biopsying these. You've got round and milk of calcium calcifications or layering calcifications. And let's look at the round ones first. Oops. Now, a normal TDLU will get calcifications in the acini in many people. And initially, the acini balloon out and get filled with fluid. You get calcifications that float around in those acini. On a lateral view, they may layer out. But at some point, the acini atrophy, usually age-related, the fluid dries up, and you're just left with the leftover calcifications with no fluid. And we call them involutional calcifications. And that's what the picture on the right is. They're involutional calcifications. You know, a few years ago, they were probably layering out in fluid in the acini. Now they're just the acini have atrophied, and you're just left with the calcifications. Beside it are calcifications, similar round calcifications, but they're probably still floating around in fluid if you did a lateral view. But not all calcifications in the acini are perfectly round or layer out. Some of them are like this picture on the right. And this is fibrocystic change. The calcifications arose in acini, but the acini were different sizes and shapes and densities. And then the acini atrophied and left behind these calcifications. Very difficult to know if these are benign or malignant. You're going to biopsy these ones unless they're all over both breasts. Here's layering calcifications. BI-RADS calls them milk of calcium. Now, the ductogram on the right is showing ballooned out acini filling with contrast or omnipaque. So calcifications that occur in these ballooned out acini, shown by on this diagram, a Tabar diagram, they're going to layer out inside these dilated acini. The acini are going to be different sizes, and so the calcifications will be different sizes. And if you did a shoot-through lateral, they'll layer out, and you'll be able to tell that they're definitely benign because malignant calcifications will never layer out. So here they are in fibrocystic change. These are small round calcifications. On the shoot-through lateral, they layer out. The main difference is when you're looking at fibrocystic change, you can do a craniocaudal view and a true lateral magnification view, and the calcifications look different. You wouldn't know they're from the same patient, but they are. And it's because on the lateral view, the calcifications layer out, just like an air fluid level does in a maxillary sinus. And when you do a craniocaudal view, you're not seeing the calcifications layered out because you're not doing a lateral view. So when you look at them, they look different. And sometimes you can see in this lateral view, the calcifications layer out quite obviously, but sometimes if the acini are really, really small, you won't see a long horizontal layer. You'll just look punctate. But when you look from one view to the other, you'll notice that on the lateral view, you'll see the calcifications better because they're layering out, even if you don't see a long linear layer. Here's another case. Now, I photoshopped these images on the cranial caudal so you can see these calcifications, because sometimes you can barely see it on the cranial caudal. But in this case, you can see these round, sort of vague calcifications, different sizes and shapes. And when you look on the lateral, they're just a little sharper, a little crisper. They don't look round like they do here because they're layering out. And the difference from one view to the other is key. So when you look at lobular morphology, there's the pleomorphic fine or heterogeneous or coarse calcifications that are DCIS or fibrocystic change or fibroadenoma most commonly. There's the amorphous calcifications that are DCIS or sclerosing adenosis or fibrocystic change. And then you have the round involutional calcifications or fibrocystic change or the layering calcifications. Those are the different types of calcifications that you have. Here's an example of a different one, linear calcifications. These are benign. This is a calcified suture. And where the arrow's pointing, that's a knot. You don't often see calcification in the sutures, but you do from time to time. These are sebaceous duct calcifications. They're calcifications in the skin. They're round ring-like calcifications with a central lucency, more common in the sweatier areas of the breast, the axillary tail, the inframammary crease. I better look, this is dermal. This is in a mole. This is probably talcum powder in a mole on the skin surface. You don't want to be biopsying them, but you may have to do sometimes tangential views and check carefully if the patient has moles on the skin, because things can get in those moles and mimic calcifications. Here's an example of that. This is dermal calcifications. You can see them in the skin here. Right beside them, there's another pleomorphic cluster of calcifications, but these ones are also in the skin when you do tangential views. So watch out for that. If they look like they could be in the skin, do tangential views and see if they are in fact in the skin. Here's coarse heterogeneous calcifications, but these are associated with a density, a mass. So this is going to be invasive ductal carcinoma with DCIS. If you think that some of these calcifications are linear and branching, then that would be invasive ductal carcinoma with high-grade DCIS, more likely high-grade DCIS anyway. Again, just another case of pleomorphic calcification. Some are coarse, some are fine, and this is DCIS. Now, this is coarse, chunky calcifications. This is a patient who has dystrophic calcifications. She had whole body radiation when she was younger for leukemia and got dystrophic calcifications. Her breasts are both incredibly distorted related to that prior radiation. And this is a case where we make mistakes and we don't want to. This is a lady who had breast reduction surgery and a couple years later develops a mass behind her nipple. And this is really common with breast reduction surgery. The nipple has to be reimplanted to be in a normal position because with breast reduction surgery, the nipple ends up at the bottom of the breast and they retransplant it to be in a normal position. So you tend to get a lot of fat necrosis behind the nipple. And sometimes after surgery, there's nothing palpable. But a year later, 2 years later, excuse me, you get a fibrous rind around the fat necrosis behind the nipple, and it becomes palpable. But often within the fat necrosis, you get calcifications. Now, here's the cranial caudal in the same person. You can see some of these calcifications look linear and branching. Here's the mag view. There's linear, branching, irregular calcifications. The key here is these are located in fat tissue. And that tells you this is fat necrosis. And if you leave them alone, the fat necrosis will progress. And this is what you want to do. You want to leave them alone. Here it is in 2007, 8, 9. The calcifications and the soft tissue the fat necrosis gradually becomes more compact, more densely calcified. But you don't want to take a patient like this and do a biopsy of those calcifications. It doesn't improve the fat necrosis. And next year, when she comes back, she'll have more calcifications. They'll look different. You'll biopsy them again. I've seen people who've had their dystrophic calcifications biopsied half a dozen times. And the only reason they're not biopsied a seventh time is because they stopped coming for mammograms. They refuse to come. Now, here's multiple calcified fibroadenomas. We biopsy way too many fibroadenomas. There's a spectrum. They go from having no calcifications to one or two calcifications to having small clusters of calcifications that gradually get coarser and coarser and coarser. And at some point, the calcifications are going to look pleomorphic. And you're going to want to biopsy them. You want to look and see, are they in a mass? Because you don't want to be biopsying every fibroadenoma. 1 in 4 women have fibroadenomas. And as you follow them, the calcifications will get more and more coarse. And often they're multiple. Fibroadenomas are frequently multiple, and that's a tip-off as well. But you don't want to be biopsying fibroadenomas. Now, this is one that, most cases of DCIS are in a segmental distribution. These look like they're more multi-segmental. And there's all kinds of soft tissue associated with this. So this is, I just added this slide in. This should say high-grade DCIS and invasive carcinoma spanning 10 centimeters. So this is really locally advanced breast carcinoma. And so this is more extensive. It looks like it's not one segment. It looks like it's multi-segmental. Again, here another case of DCIS with multiple clusters of pleomorphic microcalcifications. And here's one of the last cases. These are linear calcifications. They don't look malignant. They look, but they're clearly in a duct. The duct is branching. There are multiple small fragments within the duct. We did biopsy these, and this proved to be fibrocystic change. There you are, it happens. It's pretty uncommon. I've been doing this for a long time. I biopsied one case like this. Most of the linear branching calcifications you see that you're biopsying are high-grade DCIS. These are calcifications, of injections. This lady was injected with paraffin or mineral oil as part of a breast augmentation in China. And now she's got sort of granulomas and calcifications extending into the lymph nodes. It's just an unusual thing, but once in a while you see it. It's hard to interpret the mammograms. The only thing I want to leave you with is microcalcifications, if they are malignant. About a quarter of the cases of malignant microcalcifications will be stable for up to 5 years. So when you look at calcifications and say you don't know what they are, I'll follow them in 6 months, a waste of time. The chances are that they're going to be stable in 6 months. Either biopsy them or ask your colleague to assess the patient, because following up microcalcifications at 6-month intervals is of no value. If you think they're benign, you can follow them in 1 or 2 years. Both benign and malignant calcifications may increase in number or decrease in number, or increase in coarseness or decrease in coarseness, but there's no role for looking at calcifications and saying, I'll get a 6-month follow-up. If you think they're benign, a 1-year follow-up is more than adequate. If you're not sure, then just biopsy them. But 6-month follow-up, waste of time. On that note, ladies and gentlemen, I want to thank you. And that's where I'll end.
Thank you, Dr. Minuk. That was a phenomenal session. Before we move on to question, I would request everyone for those who are watching us live, to hit the like button, just to show how amazing the talk was. And if you're not subscribed, subscribe to the Radigan YouTube channel. We've got a couple of questions, Dr. Minuk. So Anaya asks, how can we suspect calcifications in skin on mammography?
No, you'll have to, I'm half deaf. You'll have to repeat that.
Okay. And another question, like he or she asks, is there a way to diagnose layering calcifications on CC and MLO views only?
On the MLO view, calcifications may layer out. So when you're doing a 4-view mammo, you may see the calcifications layer out and not have to investigate them anymore. Some calcifications, you can't tell they're layering out on the MLO view, but if you see them, absolutely, you can stop there.
Okay. We have another question from the audience. So I'm not sure if you're aware, but in India, the radiologists themselves do the ultrasound. So they are very well versed with the techniques, and they're very good at ultrasound. So the question here is, so in countries where breast screening programs are not available, so availability of stereotactic biopsies is not consistent and it varies. Are there any tricks which we can use to localize these calcifications for surgical biopsy on ultrasound or ultrasound correlation?
Yeah, when we look at calcifications, I mean, it's quite good to do ultrasounds of them to see if there's a solid component associated with them. On the new ultrasound equipment, you can often pick up microcalcifications on ultrasound, not the pleomorphic, not the fine calcifications, but some of the coarser calcifications or the linear branching ones you can see, and you can biopsy in ultrasound, or you can localize them in ultrasound. But you still need a mammogram because the extent of disease for malignant microcalcifications will be best seen on the mammogram, not the ultrasound. The ultrasound may be helpful to guide a biopsy, but I don't know that I would be localizing calcifications for surgery on ultrasound unless the mammogram shows that they're in a 2-centimeter cluster and you can see it on ultrasound. Then you could put a seed in or a wire in on ultrasound quite comfortably.
I think that answers that. With that, we have ended. We don't have any more questions. I think just let me check once before. So okay, so there are no more questions. Thank you, Dr. Minuk, once again for this amazing talk. And I'm sure residents and radiologists who are keen on breast imaging would find this really helpful. Just to before I finish, I would like to tell you all that Dr. Minuk is a senior radiologist. He's been practicing his radiology since 1983, and he's been head of various he's been the head of various breast imaging programs, including our provincial screening program. So thank you, Dr. Minuk, for taking out time on this weekend, and hope you. Glad that you could do this for us.
Amar, thank you very much. I think what you're doing for residents and people is absolutely unbelievable. Thank you.
Thank you. Thank you, everyone. That was Dr. Minuk. Hopefully you liked the lecture. Let us know in the comments what you would like to see next from us. Hit the like button, subscribe to us, and make sure you share the video with your friends and colleagues. We shall see you guys on next Saturday. Before you check out these videos which YouTube is showing you for a particular reason. Thank you. Bye-bye.